This is the time for revision of the pediatric module, and as usual I will project some of the cases, and you can give your answers through the chat. Then if there is any comments, I will handle. This is the first case. And what do you think about this case؟ سكت العيال يا أستاذ شديد علشان هيطلع صوتهم في التسجيل. طبعا and this is hydatid disease, multiple hydatid cysts موجودين في ال cerebral hemispheres. المريض the patient is injected with contrast, and the lesions are not enhancing diagnostic of multiple hydatid cysts. The next case, CT and MRI. Yes, and this is pilocytic astrocytoma, a cystic lesion in the cerebellar vermis with a solid enhancing mural nodule, as seen in the CT scan as well as the MR images, with supratentorial obstructive hydrocephalus. Next case, in CT and MRI with diffusion and ADC map. Yes, and this is the right answer. This is an epidermoid cyst, and in the left cerebellopontine angle. The cyst is not enhancing but shows evident diffusion restriction, diagnostic of epidermoid cyst. Next case. No, this is not BXA. The lesion is solid and is homogeneously enhanced and is located in the occipital horn of the right lateral ventricle, with significant perifocal edema due to CSF trapping in the occipital horn, and this is characteristic of intraventricular meningioma with internal calcification as well as a smooth margin and homogeneous enhancement. Next case. No, this is not a colloid cyst, but is a big supracellular lesion with a solid enhancing component and an internal cystic component with a high signal in the T2 and in the T1 weighted images, and this is a classic case of craniopharyngioma. Next case. And this is not a dermoid cyst. I think this is not the answer, but here the answer is tuberous sclerosis, right? Tuberous sclerosis, multiple subependymal tubers, and the tubers are enhancing as well as a big one in the frontal horn, that contributes to the diagnosis of subependymal giant cell astrocytoma. And this is tuberous sclerosis with subependymal giant cell astrocytoma. Next case. Yes, and this is the right answer. A classic case of Sturge-Weber syndrome. There is the cortical gyral pattern of enhancement, and this will appear on CT with some calcification associated with ipsilateral loss of volume of the affected hemisphere and enlargement with a strong enhancement of the choroid plexus on the affected site. Next case, there is a lesion in the right temporal lobe. This is T2 and this is flare and this is post contrast and this is spectroscopy. Okay, and here you see that the part of the lesion is enhancing, and the MR spectroscopy showed significant elevation of the choline peak with the depression of the N-acetyl aspartate peak, denoting that this is a neoplastic process. And also, if you can see this image where the voxel is placed a little bit away from the site of the lesion, but still shows evidence of a neoplastic lesion with elevation of the choline and some depression of the N-acetyl aspartate, denoting that this is a high-grade glioma with an infiltrating edge and is not a metastatic deposit, because if you put the voxel outside the lesion in cases of metastasis, you will see normal brain curve. Next case. Yes, and this is BXA or pleomorphic xanthoastrocytoma. Is cyst with an enhancing mural nodule in the supratentorial area, and the nodule is superficially located near the surface of the brain, diagnostic of pleomorphic xanthoastrocytoma. Next case, MRI T1, and this is flare or proton density T2 and diffusion. Yes, right answer. This is a cerebellopontine angle arachnoid cyst. This is not the usual location for arachnoid, but it can occur in this particular area. The difference between arachnoid and epidermoid is that the arachnoid cyst will appear similar to the CSF in the flare or proton density images, and it will show diffusion, free diffusion. But the epidermoid cyst will have different signal from that of the CSF and the flare images, and it will show restricted diffusion. Next case. Yes, and this is not a bilateral epidural hematoma, but it is a giant epidural hematoma. Epidural hematoma can cross the midline and extend to the opposite hemisphere, but the subdural hematoma cannot cross the midline and it will descend in the falx. But here you see the blood is crossing the midline to the opposite side, and this is a big or massive epidural hemorrhage. Next case. Okay, and this is a cystic lesion present in the thalamus, and this lesion showed an enhancing mural nodule, classic of a pilocytic astrocytoma. But you know that the commonest site for pilocytic astrocytoma is infratentorial, but it can of course occur in the supratentorial area. This male child with high-grade fever for 10 days and chorioathetoid movements on the right side of the body. This is CT and MRI T2 weighted images. Okay, and you have two big masses in the thalamus, and these masses exert a significant mass effect on the third ventricle with the supratentorial obstructive hydrocephalus, and you know that this is a bilateral thalamic gliomas, and this is one of the entities seen in the pediatric age group. The case can also fit for the diagnosis of lymphoma, but you know that lymphoma is a sizable mass with little mass effect on the adjacent structures, but this is an aggressive mass with marked mass effect on the third ventricle. This is the some informations about the bilateral thalamic gliomas. They are rare, low-grade types of astrocytoma, occurs usually in children and young adults, present by headache, vomiting, and movement disorders, and sometimes mental deterioration and behavioral impairment, such as personality changes and or dementia. The CT and MRI shows expansion of both thalami. Usually this is symmetric but can be asymmetric, of course, and there is associated hydrocephalus due to compression of the third ventricle. In the T2 and the flare, they appear hyperintense. In the T1, they show isointensity. In the diffusion, there is no diffusion restriction as similar to any of the brain tumor. And whenever you inject contrast material, it will not enhance, as you can see in this image, because this is a low-grade astrocytoma. Next case. Of course, the cause of fever is not known for me, but I quoted this case from the internet, and I gave you the history as such, and I don't try to mislead you in for the diagnosis, but I give you the history given by those who handled this case. And this case is adrenoleukodystrophy because you can see the changes in the white matter are predominantly located posteriorly, and they are almost symmetric, and they show the leading edge, which will show post-contrast enhancement, as you know. This is classic appearance of adrenoleukodystrophy. CT of the brain after contrast injection. No, these are not metastases. These lesions are classic for tuberculomas. You see the buttonhole or the ring enhancement, which is very thick, and internal relatively hyperdense contents due to the presence of caseous material. They are surrounded by perifocal brain edema because they are active tuberculomas. This is classic appearance of tuberculomas in the brain, and you should be careful about the diagnosis of metastasis, especially in the absence of a known primer. Next case is a male, 35 years old, with generalized tonic-clonic seizures. Yes, and this is a classic appearance of cysticercosis in the brain, neurocysticercosis. You can see the cyst with a dot, which is a classic sign of cysticercosis, clearly identified on the CT scan and also an MRI T2 weighted image, and sometimes seen in the FLAIR, but they are difficult to be appreciated in this MR post-contrast image. This patient, female, 20 years old, with long-standing epilepsy. Yes, and this is subependymal heterotopia with multiple subependymal nodules that are identical to the cortex in all pulse sequences, and they do not show contrast enhancement after injection of contrast. Next case is a male child, 4 years old, presented by recently treated for pneumonia, and he has persistent headaches and lethargy. Yes, and this is epidural empyema. We usually say abscess for those inflammatory collections inside the brain substance. But if they are located in the epidural space or in the subdural space, we usually call them empyema. And this is subdural empyema because it involves a good part of the cerebral cortex, or extend over a good part of the cerebral cortex. And you know that epidural collections are usually limited to a small area, and they do not extend usually for such a distance. Next case is a female 9 months old with macrocephaly and developmental delay. Yes, and this is the right answer, glutaric aciduria type 1, where you got some atrophic changes in the frontal lobe, marked dilatation of the sylvian fissures, giving the configuration of the bat's wing appearance. This is an autosomal recessive disease, and this is the incidence 1 per 100,000. There is accumulation of glutaric acid in the brain tissue and body fluids, presents in infancy with bat wing appearance with high signal in the basal ganglia, bat wing appearance due to dilatation of the sylvian fissures, and the treatment is in the form of low protein diet, fluids, vitamins, and the frequent meals. This should be provided along the whole life. Next case, and this is MRI T2 and MRI T1 post contrast. Yes, and this is a classic case of GBM or glioblastoma multiforme with the classic pattern of enhancement, marginal non-uniform, significant perifocal brain edema, and significant mass effect. Next case, there is some congenital abnormality in the brain, and these are the diagnostic possibilities: hydranencephaly, hydrocephalus severe, bilateral schizencephaly, a lobar hollow prosencephaly. Yes, and this is hydranencephaly because of the presence of the falx, which is one of the best indicators for this diagnosis, which is hydranencephaly. Next case is a chest of a child 7 months old with shocking episodes. Foreign body annihilation on the left side. This is inspiratory film and this is expiratory film, where you got hyperinflation in the left lung, which is not deflated on expiration. Extremely diagnostic of foreign body annihilation in this particular age group. Next case. Tension pneumothorax, right answer, but lobar emphysema is not. This is a big amount of air compressing the whole right lung and associated with contralateral mediastinal shift as well as depression of the diaphragm, diagnostic of tension pneumothorax. Next case is a female child, 3 years old, with fever and cough. Yes, this is right answer. Round pneumonia. You got a rounded lesion in the left lung base projected posteriorly in the lateral view, and in the presence of this positive history of infection, you should diagnose the possibility of round pneumonia. 9 years old male child with bilateral pulmonary lesions. Yes, and this is bilateral arteriovenous malformation. You got pulmonary nodules with dilated vascular pedicle connecting the nodules to the hilum, and this is bilateral pulmonary arteriovenous malformation. Next case is a babygram or whole X-ray of the chest and the abdomen. Yes, and this is congenital diaphragmatic hernia. Multiple uh, multiple bowel loops are located in the left hemithorax, connected to air in the bowel loops in the abdomen, and this is the classic appearance of congenital diaphragmatic hernia. Next case is a chest X-ray, AB and lateral. Lung abscess, right answer. Thick-walled cavity with air fluid level. The fluid is straight, and this is a classic diagnosis of lung abscess. Next case, and this is male, 30 years old, with history of mineral oil aspiration, admitted to the pediatric ICU because of cyanosis and severe respiratory distress, treated by multiple bronchoalveolar lavages. Yes, and the history is quite evident, and this is laboid pneumonia, and this is the appearance of the case by CT, and this is CT after bronchoalveolar lavage. Actually, this is a usual type of pneumonias, and you cannot reach the diagnosis of lipoid pneumonia except you have this positive history of aspiration of mineral oil or the use of suppositories containing mineral oil or something like this. But if you are not provided by such an history, you are allowed to diagnose this as bilateral pulmonary infections. Next case. Yes, and this is hamartoma, smooth margin, popcorn calcification, diagnostic of pulmonary hamartoma. Next case. Lobar emphysema, no. And this is, yes, this is neuroendocrine cell hyperplasia, which is one of the diffuse lung diseases in the pediatric age group. And this is the classic appearance of neuroendocrine cell hyperplasia by the detection of ground glass appearances, is particularly in the lingula and in the middle lobe. You may see also some changes in the other parts of the lung, but this is very characteristic for neuroendocrine cell hyperplasia. Next case is a female, 26 years old, with patchy opacity in the right lower lobe. Yes, and lung sequestration, right answer. And if you look carefully here, and you can see that there is a vessel coming directly from the aorta to the infected area or the consolidated area, diagnostic of pulmonary sequestration or sequestrated lung segment. Next case. No, this is not a tracheoesophageal fistula, but there is esophageal atresia because the nasogastric tube is coiled in the upper part of the esophagus. There is no evidence of tracheoesophageal fistula because there is no gas in the abdomen. This is esophageal atresia. Next case. And you have got the answer here. This is widespread ground glass opacities with some air bronchogram in a premature neonate born by emergency cesarean section with increased oxygen requirement. He is only 1 day old, and you got the classic appearance for respiratory distress syndrome or hyaline membrane disease. And this disease is well known in the premature infants, and the literature consider hyaline membrane disease is more accurate than respiratory distress syndrome, and is seen in infants of diabetic mothers. They are at risk to develop this particular disease, and there is deficiency of surfactant, and this will lead to collapse of the alveoli and increase the respiratory effort, as I explained in the literature. In the X-ray, you can see poor inflation of the lung with diffuse ground glass appearance. You may appreciate some air bronchogram, and the clinical improvement will follow often with the diuretic phase, where you got clearance of these opacities. Next case is a male child, 12 years old, with a cavitary lesion in the right lung. Yes, and this is ruptured hydatid cyst, a classic appearance with wavy appearance of the air fluid level, diagnostic of hydatid disease or ruptured hydatid cyst. And this is a case of intestinal malrotation. Usually you should see the jejunum to the left side of the spine, but here you see the jejunal loops are to the right side. This is intestinal malrotation, which is not usually symptomatic and is incidentally found. There is no associated obstructive changes. And this is also a normal appearance of the pediatric abdomen X-ray. The child swallows too much air. Then you got air delineation of the stomach, small and large bowel loops. Okay, and then this is also a good case for duodenal atresia, or what's known as the double bubble sign. The stomach and the proximal part of the duodenum are markedly distended, proximal to complete obstruction in the duodenal loop. If you see in a pediatric patient or an infant, multiple dilated bowel loops and multiple air fluid levels, you should look for the number of these fluid levels in the stomach only, and this is gastric outlet or pyloric atresia. In the stomach and the proximal duodenal, which is known as double bubble, and this is duodenal atresia. In the stomach, in the duodenum, and in the proximal jejunum, and triple bubble, and this is jejunal atresia. While if you see multiple air fluid levels reaching to the ileum, and this is ileal atresia. This case is this case is meconium ileus. You see multiple filling defects in the terminal part of the ileum as well as in the ascending colon, which are mentioned in the literature to simulate the rapid pellets. These are some of the food given to rabbits, and they may be similar to the impacted meconium. Big mass in the left kidney with characteristic claw sign, diagnostic of neuroblastoma. Massive air in the abdomen, diagnostic of pneumoperitoneum. And this infant, you got calcification within the peritoneal cavity, and the only diagnosis for this is meconium peritonitis. Thank you very much.